Many of the factors that I used prior to Oncotype was clinical features, which have been shown that putting together those clinical features don't necessarily add up. There's a lot of variations across reading of these pathologic features. It really justifies using the Oncotype. There's a chance that using those clinical parameters alone, you'll be wrong. And those patients might have higher risks of recurrence and you're not even aware of it.
Prior to having Oncotype DX, we relied on our pathologist and pathology reports. So we looked at the grade of the tumor, we looked at the size of the tumor, we looked at how ER and PR positive the tumor is. And obviously this has limitations. The grade is really very subjective. If you have different pathologists looking at the grade of the tumor, they might grade it differently. By using Oncotype DX, we have a much more objective test that can help us with the decision on whether to offer chemotherapy to our patients.
I hear a lot of people say, well, I could guess what the result will be or whether or not someone would benefit from chemotherapy, but many of those subjective criteria like grade and things like certain clinical pathologic criteria, things from the pathology report, I think the data shows that you might be right some of the time, but you'd be wrong a significant percentage of the time, and then you're risking under or over treating patients. So I'd rather have the actual data, see the score, and know for sure that I have something to back up my treatment recommendation. And obviously, we do this with our multidisciplinary colleagues. So I think it's also important to make sure that everyone's in agreement of who should have the test and who is going to act on it.